In this video, we're going to talk about the pathophysiology of diabetic ketoacidosis, as well as some of the consequences that we see when someone is experiencing fairly severe DKA. So in order to talk about diabetic ketoacidosis, we first have to look to our pancreas and find out how we get into a position where our beta cells have become destroyed to the point where we have an absolute reduction in insulin. And that's going to be an important key concept that we're going to talk about throughout this video, is that people who experience diabetic ketoacidosis typically are not experiencing a pathology in which some of their beta cells still function. These individuals have had total destruction of beta cells, and as a result, they can't produce any insulin whatsoever. So if we look at our pancreas here, so what I've drawn in here is our pancreas. And in our pancreas, we have a number of cells. And the important ones that we're going to talk about are the beta cells. The beta cells live within the islets of Langerhans. So that's this internal piece here of the surrounding cells. And these surrounding cells are called the acinar cells. These are the cells that are going to release things like pancreatic enzymes in order to break down things like proteins. So within here, we have our beta cells. So these little blue guys here are going to be our beta cells. So within these little Langerhans, we have our beta cells. And the beta cells are responsible for releasing insulin. So typically what happens is when we recognize an increase in blood glucose levels, the beta cells will release insulin. So these beta cells will release the hormone insulin. So we'll see insulin release. And insulin's job is to store glucose. So we'll use green to indicate glucose in the blood here. So say that these green circles are glucose in our blood. As your body recognizes that blood glucose levels are going up, the beta cells will release insulin, and insulin will bind to the insulin receptor on our body cells. So especially in the places where we're going to store a lot of glucose, so picture things like our skeletal muscle cells, cells within our liver, and cells within our adipose tissues. So this is our insulin receptor. And a couple of things happen. So insulin will bind to the insulin receptor. So we'll see insulin binding to this insulin receptor. So insulin will bind here to the insulin receptor and will lead to an intracellular signaling cascade in which we see increased production and upregulation of the GLUT4 transporter. So what happens here is we start to see an increase in GLUT4 on the cell membrane. So we take the GLUT4 transporter and we start to see an increased presence of GLUT4 transporters on the cell membrane. And what that is going to allow for is for glucose to now make its way into the cell. So insulin binds to the insulin receptor. I start to see an upregulation in the GLUT4 transporter on the cell membrane. And that's going to allow for insulin to make its way into our cells, and we can have cell storage of glucose. If you think about the benefit of this, it's going to allow the cell to conduct metabolism, in which we can break down glucose for energy. I can store glucose for later. So that's the whole function. Insulin is responding to an increase in blood glucose levels in order to store glucose within our cells to support metabolism and the storage of glucose as glycogen for later use. What we have to think about in the patient who has diabetic ketoacidosis is how do we get to a point where we don't have this insulin? So for some reason, this patient does not have any beta cells. They end up in an absolute reduction, or they lose all of these beta cells, which leads to the loss of insulin, which means I cannot store glucose. And typically what's happening here is an autoimmune disease. So patients who end up with diabetic ketoacidosis often have autoimmune destruction of the pancreatic beta cells. So they get antibodies or immunoglobulins that are going to fight the beta cells themselves. So we get an autoimmune response. A lot of times you'll see this in patients following an viral infection. So viral infection promotes increased antibody or immunoglobulin production. And if the patient has a predisposition to diabetes, autoimmune response is going to self-target the pancreatic beta cells. So what you actually see is self-targeting and destruction of the pancreatic beta cells by these autoimmune cells. And what starts to happen is we destroy the pancreatic beta cells and the patient is left with none of them. Typically, when you see diabetic ketoacidosis, this is a patient who has upwards of 90% beta cell destruction and has essentially lost all of the insulin that they need to function properly. So what happens is you get this autoimmune response, which destroys the pancreatic beta cells, and the patient ends up with an absolute reduction in insulin. So what we need to think here is that this patient has no insulin being released. So we see an absolute decrease in insulin production. So what that means, if I have an absolute reduction in insulin production, is I cannot bind to my insulin receptor, and we can't have this upregulation of GLUT4. So if we take a look at our membrane, what starts to happen is we don't have these GLUT4 receptors that we need, or we don't have these GLUT4 transporters that are going to allow for glucose to be positioned into the cell. So glucose begins to build up, and that's how you end up in diabetic, or it's one of the challenges or one of the consequences of diabetic ketoacidosis is we start to see the blood glucose levels going up substantially as the patient cannot store glucose. So the challenge is we have no GLUT4 transporters, which is subsequently going to lead to an inability to store glucose. And the result of this is going to be an increase in blood glucose levels. So one of the things that we're going to see as a consequence of this is an increase in BGL, where your blood glucose levels go up, which is probably one of the more known consequences of someone having diabetic ketoacidosis. Now, the other thing that we're going to see happen is the cells become starved. So we start to see cell starvation as we don't have glucose entering the cell. So as no glucose is entering the cell, what we start to see as a consequence is cell starvation. So although we have a lot of glucose in the blood, this glucose is not making its way into the cell, and the cells are beginning to starve, which is going to lead to a number of the significant consequences of diabetic ketoacidosis. So we get cell starvation, which is going to trigger a couple of different things. One is that cell starvation is going to lead to the release of counter-regulatory hormones. So if the cells believe that they're not obtaining enough glucose, or that they're not getting enough glucose for metabolism, they start to trigger the release of counter-regulatory hormones. So we see our cell starvation is going to trigger the release of counter-regulatory hormones, and this includes things like glucagon. It includes things like cortisol, epinephrine, and growth hormone. So we trigger the release of counter-regulatory hormones. And these hormones are the hormones that are going to lead to an increase in blood glucose levels. So again, if you think about what's happening here, if my cell believes it's starved, it thinks that there's not enough glucose coming into that cell in order to provide energy for metabolism. So to correct that problem, one of the things you'll see is the release of these counter-regulatory hormones. So again, this includes things like cortisol, epi, growth hormone, and glucagon, which are going to trigger a couple of different things. One of the consequences of counter-regulatory hormone production is going to be proteolysis and lipolysis in order to promote gluconeogenesis. So we start breaking down things like fats and proteins to create the byproducts necessary to make glucose. So we start to see an increase in proteolysis. We're going to create, produce amino acids, and we're going to have lipolysis, which produces free fatty acids. So we do proteolysis and lipolysis, which is going to create glycerol, fatty acids, amino acids, all which are going to help support gluconeogenesis, or the formation of new glucose. So part of the byproducts of this, like I said, are things like glycerol, amino acids, fatty acids, and they're going to support the creation of new glucose. So if we look at the glycerol and the amino acids that are being produced, they will be transported to the liver to support gluconeogenesis, or the formation of new glucose. So we see gluconeogenesis, which is going to lead to the formation of new glucose. What you start to see is, again, a further increase in blood glucose levels as a result. So if we go back to our blood supply, this is going to lead to more glucose entering the blood supply, and we'll highlight this kind of connection in green. So if I get an increase in blood glucose levels, think about that in terms of the glucose in the blood. Now I'm not storing that glucose very well, so that's leading to just having more glucose in the blood, period. And not only that, I'm making more glucose. So I'm exponentially increasing the amount of glucose that is going to be found in the blood. So I get gluconeogenesis as the result of the lipolysis and the proteolysis. One of the other consequences to this is the metabolism of those fatty acids. So as we look at free fatty acids being transported to the liver, This is where we get that ketoacidosis portion of diabetic ketoacidosis. As free fatty acids go to the liver and they're metabolized by the liver, what you start to see is ketones being created. So as a result, we'll see metabolism of those free fatty acids in order to form ketones. And more specifically, when we look at metabolism, what we're creating is beta hydroxybutyrate and acetone. So as those free fatty acids are making their way to the liver, they're seeing metabolism. Traditionally, you see the free fatty acids being converted in via beta oxidation into acetyl-CoA. And then ultimately, the byproducts that you see as a consequence of this are acetone and beta hydroxybutyrate. And these are the acidic byproducts of free fatty acid metabolism in the liver. And this is the core reason why we see metabolic acidosis. So the production of our ketone bodies are going to be what are going to lead to the metabolic acidosis that someone experiences in DKA. So when you look at diabetic ketoacidosis, that is one of the really big ticket consequences, is the formation of these ketone bodies. So this is where we start to see ketoacidosis. So that's part of it, is we get the release of these counter-regulatory hormones that's going to promote lipolysis, proteolysis, which is going to lead to gluconeogenesis and the formation of new glucose, which is going to increase the blood glucose level. We know the fatty acids, which are a byproduct of this lipolysis, are going to undergo metabolism in the liver and form acetone and beta hydroxybutyrate, which are keto acids and are going to make the ketoacidosis portion. The other thing that you start to see as the result of counter-regulatory hormone release is we're going to break down glycogen, or the glycogen that is found in the liver is going to be broken down. So these green stores over here are glycogen, and what you get is glycogenolysis, or basically the breakdown of glycogen. So one of the other consequences, or the other kind of final consequences that we need to talk about when we look at the release of these counter-regulatory hormones, is that the counter-regulatory hormone release is going to lead to glycogenolysis. So release of counter-regulatory hormones promotes the breakdown of glycogen, or we get glycogenolysis, which is going to create a further increase in blood glucose levels. So again, it's just one more mechanism through which the blood glucose levels are rising. So we see an increase in blood glucose levels. So again, if we picture the blood again, now because we have both gluconeogenesis and glycogenolysis going on, we're seeing a further increase in blood glucose levels. So we start to see those blood glucose levels really starting to ramp up as the patient is not able to store glucose. So if you think about the reasons in which someone has an increase in blood glucose level, one is that they can't store glucose levels, or can't store glucose. So when we look at the reasons before the increase in BGL, one is no GLUT4, so we can't store glucose. So no GLUT4 equals no glucose storage. The other consequence that we see, or the other two consequences, are related to counter-regulatory hormone release. So we know that as we can't store glucose, what's going to happen is the cells are going to starve, and they're going to promote the release of counter-regulatory hormones. And the other two consequences of why we start to see blood glucose going up, two, is we start to see an increase in gluconeogenesis. So the body is going to make new glucose. And the other thing that we're going to see is an increase in glycogenolysis, or the breakdown of glycogen. So those are the reasons in which we see the increase in blood glucose levels. If we think about why we see the acidosis, so why do we see an increase in hydrogen ion concentration, or essentially why do we see acidosis? The reason for this is related to lipolysis. So we get an increase in lipolysis, which creates an increase in free fatty acid metabolism in the liver, which is going to create ketoacids. And the reason why this is so prevalent in someone with type 1 diabetes, or if we go back to this absolute reduction in insulin, it's because the body has no ability to store glucose. If there was a little bit of glucose trickling into these cells, or we had a tiny amount of insulin that caused some binding, like we see in the type 2 diabetic who still has some insulin release, then the cells are not going to starve nearly as much, and we don't get as much of this gluconeogenesis, or we're not having as acute of lipolysis and proteolysis. The big problem for this patient is with no insulin, when we have an absolute destruction of our beta cells and an absolute reduction in insulin, there is no binding to the insulin receptor, which means that no GLUT4 is being upregulated onto the membrane and no glucose is being stored. So the amount of lipolysis happening is really quite severe. So what we'll do from here is we'll talk about, well, what are the consequences of this? We know we're getting an increase in blood glucose level. We know we're getting an increase in acidosis. What are the big problems associated with that? Now that we've spoken about the basics of diabetic ketoacidosis, we can take a look at what the impact of this high blood glucose is on some of the other body systems and how this plays an important role in causing something like hypovolemia and electrolyte imbalance in the patient who is experiencing diabetic ketoacidosis. So one thing we have to remember is that the blood glucose level is high, and that's the first thing that we're going to speak about is what are the consequences of having a blood glucose level that is now high. So we understand that one of the consequences of diabetic ketoacidosis is that our blood glucose level is going to go up. But what does that mean in terms of impact on the patient? So what we'll start with is how this changes osmolarity. So one of the things that we have to remember is that glucose is a large molecule and it's going to have hyperosmolar properties. So what that means is when we have an increase in blood glucose level, the intravascular compartment becomes hypertonic. So what we're seeing is the intravascular compartment is becoming hypertonic, or essentially what that means is that the intravascular compartment is going to want to draw fluid out of the cells and interstitial tissues and into the vascular space. So it would be no different than if we had a whole bunch of salt living in our blood, and that salt is drawing water or fluid away from the cells or the interstitial space. So one of the consequences of an increase in blood glucose level in a patient having diabetic ketoacidosis and this increase in blood glucose level is the hypertonicity of the blood is going to result in fluid shifting. So what we can expect is that fluid will shift from the interstitial spaces and from the cells, so our extravascular compartment, into our vasculature. So one of the big consequences that we see with an increase in blood glucose level is we get a hypertonic intravascular space. And what that's going to lead to is fluid shifting. So we know that the hypertonicity of that intravascular space is going to lead to fluid shifting, or we see extravascular fluid shifting. So we're going to deplete our cells and our interstitial space of the fluid that they have. So we see extravascular fluid shifting and depletion. So when we look at these patients, this is typically where you're seeing those signs and symptoms of dehydration. Or it's part of the reason why we see dehydration in these patients is because we're depleting those spaces. So some of the consequences of this, for example, are going to be dry mucous membranes, poor skin turgor, delayed capillary refill. So this is going to be related to those specific signs and symptoms. So the patient will be dry, poor turgor, a decrease in cap refill. One of the other problems is that we know as we increase, so think about what has happened for this patient. So we're saying that not only do we have an increase in blood glucose levels, so our BGL is high, so we have an increase in BGL. And when we look at the blood that's making its way to the renal tubules, we've also pulled the fluid from the extravascular space. So we have an increased blood glucose level and we have pulled fluid from the extravascular space. And this makes a difference for the patient who is now going to have an increase in urination. So we have to be really mindful of the fact that not only are we seeing an increase in blood glucose level, but we've pulled fluid out of the extravascular space and now put that fluid into the intravascular space, and it's all going to circulate to the kidneys. So we see an increase in blood glucose and we see the fluid that we've pulled from the extravascular space going to the kidneys. So what happens is we get an increase in fluid and glucose traveling to the kidneys. And one of the big problems that we have here is that a ton of glucose doesn't typically pass over the glomerulus. But when we have an increase and where blood glucose levels get too high, what happens is you start to see podocyte expansion and mesangial cell expansion. So when we look at the cells that are essentially creating tight junctions in the glomerulus, they expand, allowing for an increase in glucose to make its way over the glomerulus and into the renal tubules. So what happens next, or what we start to see, is an increase in glucose in the renal tubules. Now this has both long-term and short-term consequences. It's this increase in blood glucose in the renal tubule and the expansion of the mesangial cells that leads to renal failure as a chronic problem in diabetes. But when we look at simply diabetic ketoacidosis and the acute presentation of increased blood glucose in the renal tubules, what that means is the renal tubules will become hypertonic just like the vasculature did. So first, we see an increase in blood glucose in the renal tubules. The second issue that kind of goes along with that is that we see a change in osmolarity or the tonicity of our renal tubules. So the second issue is that we start to see an increased hypertonicity, or we see the renal tubules becoming hypertonic. So we see the renal tubules becoming hypertonic. And the same thing is going to happen here that happened in the blood supply. Is when we have a hypertonic solution, we see an excess of fluid being pushed towards that hypertonic area. So what starts to happen is we have an increase in fluid shifting into the renal tubules. So we start to see more fluid entering the renal tubules than would typically enter. And as a result, that's going to increase urination. So we start to see excessive urination in these patients. So the third thing that's happening here is we get fluid shifting into the renal tubules. So fluid shifts into the renal tubules, and we're going to lose that fluid through urination. So the patient is going to urinate more, and we're going to have fluid loss. And this is how this patient ends up in hypovolemia. So an increase in urination, which will lead to hypovolemia. The other problem that exists with this is as this patient has an increase in urination, or as they're having excessive urination, they're also losing the typical ions and electrolytes that would be lost through the urine. So this patient is going to see an increased loss of electrolytes through urination. So the patient actually becomes depleted in many of the typical electrolytes. So potassium, sodium, phosphate. So the patient is going to lose a lot of electrolytes through the urine, which is also going to lead to issues for them. So something to be mindful of, for example, is that hyperkalemia are common causes of death in someone experiencing DKA. So the other thing that we have to be aware of, or kind of one of the other big consequences, is that the patient has osmotic diuresis, or basically that's when we're seeing something like glucose creating a hypertonic environment in the renal tubules, allowing for fluid to shift in and having excessive urination. So the patient will have osmotic diuresis, or essentially they're going to urinate excessively. So excessive urination will lead to hypovolemia and electrolyte loss, which are primary life threats in the patient who has DKA. So electrolyte lead to electrolyte loss and hypovolemia. We think about the signs and symptoms associated with this. Again, this hypovolemia will relate to the symptoms we've talked about here. So dry mouth, poor skin turgor, delayed capillary refill. These two things together will lead to polydipsia, or increased drinking. So we see these patients who are often drinking a lot of fluids, and polyuria. The patient is urinating a lot. So we see polydipsia, polyuria, and then signs of poor perfusion or hypovolemia. When we look at electrolyte loss, this can lead to CNS depression, can lead to the formation of arrhythmia. So we need to be mindful of those things as well. So CNS depression and arrhythmia are common consequences of the electrolyte depletion that we see for these patients. So CNS depression and arrhythmia. The other thing that I wanted to talk about in terms of what's happening with an increased blood glucose level is that hypertonicity is seen in the brain as well. And this is one of the reasons why we need to be very cautious when we are providing fluid to patients who have diabetic ketoacidosis, is because we've seen the same thing happen, is the patient has fluid shifting out of the vasculature as a result of the hypertonicity, or out of the cells due to the hypertonicity in the blood supply. So the cerebral cells are going to be dehydrated. So as a result of fluid shifting, we start to see dehydration of our cerebral cells, or dehydration of the neurons. And the challenge with this is that the neurons will often create what's called an idiogenic osmole. So you'll see the production of an idiogenic osmole for this patient. So they create these idiogenic osmoles, which basically are an attempt to maintain the osmolar gradient in the brain. So picture these osmolar gradients as creating some tonicity within the cell, so they are creating tonicity within the brain cells. And when we give high volumes of isotonic solutions or high volumes of saline or fluid to these patients, and we reverse the gradient, we take a blood supply that's hypertonic and make it iso or hypotonic, that can lead to excessive fluid shifting into these brain cells because of these idiogenic osmoles. So it's one of the reasons why we want to be cautious with excessive fluid administration to patients who are experiencing DKA, is because the presence of those isogenic osmoles can lead to fluid shifting within the brain and can greatly increase cerebral edema and can lead to signs of herniation. So when we're looking at this patient, we look at the consequences of high blood glucose level. A couple things are happening. One, we need to be mindful of the hypertonicity of the blood. So one of the challenges with the hypertonicity of the blood is it's going to pull fluid out of the extravascular space and dehydrate our cells. One of the reasons why we get really thirsty. It's going to also promote fluid being pulled out of those spaces into the intravascular compartment. And then we know once we get to the renal tubules and we have all of this glucose making its way into the renal tubule and fluid following it, that creates the perfect storm for us to urinate out an extreme amount of fluid. So the patient has excessive fluid loss to the point of hypovolemia. And as they're losing all this fluid, they're taking valuable electrolytes with them. So the loss of sodium, potassium, phosphate, magnesium are all going to be urinated out. The other challenge that we've mentioned is the fact that as a patient becomes, or the intravascular space becomes hypertonic, we see the cerebral cells create isotonic osmoles or idiogenic osmoles, which can create or complicate the situation when the patient is given isotonic fluid. So because of the creation of those idiogenic osmoles, the patient's cerebral cells are basically primed to accept fluid when the tonicity is reversed. So in a hypertonic situation, it doesn't really matter because fluid is shifting out and those osmoles are trying to maintain some homeostasis. But as soon as we reverse this fluid gradient, so if we give tons and tons of fluid and reverse the gradient, this could be the same if we try to correct the BGL too quickly. So we give a lot of insulin, for example, and store all of this glucose. As the blood starts to become isotonic or hypotonic, we see fluid shifting into those cerebral cells because of those idiogenic osmoles, and that puts the patient at risk of cerebral edema with treatment. When we look at the consequences of diabetic ketoacidosis, we can look to two other pieces of important information. One, which we're going to speak to, is the presence of acidosis and the impact this will have on the patient. And the other is the consequences in terms of hyper or hypokalemia. And both will have significant impacts on the patient in terms of morbidity and mortality. So we'll start by looking at the impact of acidosis. So we know that as the patient enters ketoacidosis, we see an increase in acids circulating through the blood supply. So we'll use these purple dots here to indicate an increase in acid. And what we have to be mindful of in terms of acidosis are two things. As we have an increase in hydrogen ions or an increase in acidosis within the brain, that will promote an attempt at the cellular level to buffer those acids. And what that means is that we actually start to see the exchange of hydrogen ions into the cell for potassium ions, which are going to exit the cell. So one of the body's mechanisms as an attempt to mitigate this acidosis is to push a lot of hydrogen ions into the cell while pulling a lot of potassium ions out of the cell. And if we think about the consequence of this, we're going to lead to a decrease in our intracellular pH, or the pH within our intracellular compartment is going to decrease. And what starts to happen is as that pH gets to a point where the cells cannot no longer survive, they die. So we start to see cell death as our cells begin to enter a severely acidotic state. Where this can be particularly damaging is in the cerebral system as those cells die and we start to see the loss of vegetative functions. So one of the big consequences of acidosis is we see hydrogen and potassium exchange intracellularly, which is going to reduce the pH of the intracellular environment, or we start to see the cells become more acidotic. So we start to see a decrease in cellular pH, and eventually that will lead to cell death. And in the brain, one of the big challenges with this is that we start to see a loss of vegetative functions. The other problem when we look at acidosis is that acidosis will impact the ability of the cardiac myocytes to perform their function. So as we start to see an increase in hydrogen ions, we actually start to see the tension generated by the myofibrils in the heart reduced. So what we start to see is as we get this increase in hydrogen ions, we start to see a decrease in myofibril tension, which means that contractility will be impaired. So this will lead to a decrease in contractility and cardiac output. And if you think about the patient that we're looking at, this patient already has fairly reduced cardiac output as a result of the hypovolemia they're experiencing as they've lost all of those fluids. So these two things together, the impact on vegetative function and the impact on cardiac output, will promote cardiac arrest in patients. The other piece that we have to be mindful of is the impact on hyperkalemia. And this again relates well to what we just talked about in terms of cellular exchange for potassium. So one of the cell's buffering mechanisms for the increased concentration of hydrogen ions is going to be an exchange of those hydrogen ions for potassium ions. And what we start to see as a result is the blood concentration of potassium goes up in the early stages of acidosis. So we need to be mindful of what we're talking about here. So in the early stages of acidosis, what we start to see is an exchange, like we've mentioned. We get a hydrogen ion and potassium ion exchange, which will lead to an increased concentration of blood potassium. So what starts to happen is we start to see increased concentration of potassium ions in the blood. Now, the problem with this is that we know this patient is urinating excessively. So one of the challenges that's going to exist is that eventually what's in the blood will be lost to the urine in someone who's experiencing DKA. So what we start to see happen for these patients is that as this potassium is circulating to the renal tubules, and we'll put in here essentially lost to urine. We know we have all this potassium that's in the blood, and one of the challenges that is going to exist is that you're going to see loss to urination. So essentially, as that patient has that polyuria, what will occur in the later stages is we'll see the potassium levels actually reaching a more normal. So you actually can see a pseudo normal kalemia as the increase is lost. So we're saying that in the early stages, we get an increase in blood potassium as we see this shifting. So blood potassium levels go up, but then we start peeing out a lot of this. So eventually we'll go from high to normal and then low. So in the late stages, as we have urine loss of potassium, so we know we're losing a lot of potassium to the urine, we'll see levels normalize, and then we'll see the patient go into hypokalemia. So the patients are at risk of development of arrhythmia. And we've talked about this in previous videos, but the patient's at risk of arrhythmia. So we can see things like tachydysrhythmia when the patient is in hypokalemia or in hypokalemia, and then as we enter hyperkalemia, the patient can end up in either tachydysrhythmias or progress on towards bradycardia. So the risk of arrhythmia is high in these patients. In the early stages, we typically will see hyperkalemia, followed by late stages that we see hypokalemia. And again, the kind of the end consequence of this or of both are cardiac dysrhythmia. We start to see arrhythmia. And this can typically be one of the causes of cardiac arrest for these patients. When the patient enters arrhythmia, it can lead to prolonged arrest. So that's why sometimes we see these patients ending up on ECMO as they're trying to balance out the acidosis and the electrolyte imbalance. So one of the big challenges is that we often see prolonged arrest as a result of acidosis that is challenging to impact or challenging to fix, and then profound electrolyte imbalances, especially as this patient is ranging from hyper to hypokalemia. When we're talking about hypokalemia in the DKA patient, often what we see is a total body loss of potassium. So it can be challenging to correct these levels because we know most of our potassium typically lives in the cell. Well, we're pulling that potassium out into the blood and then excreting it through the urine. So even our blood values that we're getting of potassium can be skewed because we're not seeing the fact that we've depleted the potassium in the cell. We can just see what's in the blood. So often quite challenging to manage and needs prolonged management. And when these patients enter the cardiac arrest state with something like acidosis, hyper and hypokalemia, the hypovolemia that we've talked about previously, can lead to prolonged resuscitation, prolonged arrest, and need much more substantial management.